Macrophages are going to help to eat or engulf the foreign substances that are in our body. And then we have B lymphocytes, okay? And they're also going to help to attack and kill tumor cells. So we have a lot of different fighters. They're just not able to either keep up or recognize them. So how do we classify cancer anyway? Well, there's a lot of different ways to classify. One way we can classify is by looking at the anatomic site. Well, where did it come from? We can have carcinogens or carcinomas. Typically, if we use the word carcinoma, that indicates that it's coming from like an ectoderm or an endoderm or a mucus lining, lungs. Those are all considered to be carcinomas, okay? A sarcoma, an SAR, sarcoma would be more mesoderm, connective tissue, muscle. And the last anatomical site we usually classify is our lymphomas, from the lymph system or from the blood system. So using the anatomical site is one way that we can classify. Another way is we can just look at the histology, or actually look at themselves. What do the cells appear like? Do they appear like the cells that they arose from? Or have they differentiated? Are they different from what they used to be? We grade those by, if they're a grade 1, they're slightly different than the original cells. Or if they're all the way to a grade 4, they're way different. We can hardly even recognize them as being a lung cell or whatever the original cell was. Another way we can do is we can look at the anatomical site, we can look at the histology, and the third way is by looking at the extent of the disease. How much is involved, okay? When something is in its original place, here's where the rogue cell started, it started right here, and it's still right there, it hasn't moved, we call that an in situ, okay? It's in the situation, or it hasn't moved, so it's in situ. When we have cells that have gone throughout the body, or cancer has gone out through their body, we call that a metastasis. So we can have an in situ, which would be the best case scenario, or we can have the last stage, again, a stage 4, being it has metastasized through different areas of the body. So these are the 3 ways we can describe cancers or classify cancers. Another way that's very helpful is by looking at whether it's a tumor, the tumor size, okay? What is the tumor size? How big is it? That stands for T. How big is a tumor? Is it itty little bitty, or is it a great big tumor? The other thing is looking at nodes. Is there node involvement, as in lymph nodes? Is the lymph nodes involved, or are they involved? And how close are they to the tumor? And the last thing is the M, the metastasis. Has it metastasized to certain areas? So the tumor size, is there node involvement, and has it metastasized or transferred any place else in the body? Now, there are several diagnostic tools we can use to determine if somebody has cancer or if a cell is cancerous. The best is probably biopsy, actually going in, aspirating part of the cells and looking at them under the microscope and saying, are they different? Are they the same? Are they malignant? Are they benign? What is the cell? So that is one of the tools that we can use for diagnostic, biopsies, okay? We can determine what kind of tissue it is. Now, there are different types of biopsies that we might use. We might use a needle biopsy, we might use an incisional or an excisional biopsy, depending on the cancer, where it is, and how difficult it is to get to. So what are our goals in cancer treatment? Well, we have several goals. Not all of them are going to be the same goal, depending on what kind of cancer it is, depending on what's involved with it. But one of our goals might be to cure. That's probably the best. We're going to take this out, we're going to cure it. That could be our goal. That's what we all hope for, is a cure. But sometimes it's more for controlling the cancer themselves, maybe controlling the rate, controlling the proliferation, or sometimes just controlling the pain, the palliation, removing the pressure, removing the tumor, and hopefully making the patient a little bit more comfortable, palliation. So those are all some things that we might use surgery for, or might use treatment for cancer. Those are all things we might treat cancer for, sorry. So how do we treat cancer? Well, there's many ways we can treat cancer. One, probably the oldest, being surgery. Going in and excising, removing, hopefully removing the cancer cells that it can't reappear or can't grow any place else in the body. By using surgery, we might sometimes use surgery for prevention. We might have a good breast removed just to prevent spread of cancer to that one. Sometimes we use surgery for cure. Other times we use surgery for palliation. And sometimes surgery is also used for rehabilitation, to rehab the area or rebuild the area. So surgery is often used with cancer. Another thing that's used with cancer is chemotherapy. Chemotherapy is a very, most times very caustic chemical that's put into the body, and these chemicals will hopefully attack the cells that are quickly multiplying and dividing and decrease their proliferation or their overall turnover, okay? Chemo works best if, under these circumstances, when the tumors are small. It's going to work best on small ones. It's going to work best on the very young and the very new cells, and it's going to work best on cells that are dividing and multiplying very quickly. So if you're going to be using chemotherapy, that's the main criteria. Now, how do we give chemotherapy? Well, chemotherapy is given in a number of ways. One is through a tunneled catheter going right into the different areas, usually ending up in the right atrium. So the tunneled catheter is a good way. It can also be peripherally inserted in a PICC line, okay? Again, not in the peripheral veins. It can be infused in an infusion port, depending on where it is. This might be like a thoracic area. An infusion pump might be a way to put it in. A Tekoff catheter or an Omiya catheter is another one. I'm probably not pronouncing that right. But where there's a reservoir. And in this case, as remember, we have that blood-brain barrier, and it's very hard to sometimes treat cancers of the central nervous system, so they might have to have a direct port right into that brain area. Now, I said before, chemo works best on rapidly dividing cells, okay? Cells that are turning over quickly. That's where the chemotherapy can work the best, targeting those cells. But unfortunately, it gets the good cells and it gets the bad cells too, okay? So it can't differentiate between your bads and we're only going to take you out. It does take some of the good cells out too. So it's very important for your patient to know that, well, we're hopefully getting more of the bad than the good, and the patient will hopefully get much better from there.